Hello and welcome to my channel. Today we're going to continue our discussion of the cranial nerves, so let's start. We discussed the olfactory and optic nerves, and now it's the turn of the third and fourth cranial nerves, but we will study the sixth cranial nerve together with them because all these nerves are involved in the movement of the eyeball of the globe, so they should be discussed together. Also, do not forget that the oculomotor nerve is one of the nerves that carry parasympathetic supply to the eye, precisely to be precise, to the constrictor pupillae muscle and the ciliary muscle of the eye, and this controls the diameter and lens curvature within the eye. We need these reflexes to as a response to light conditions and to focus on objects. So it's the third, fourth, and the sixth cranial nerves, the oculomotor, the trochlear, and the abducens nerves. Now, a hint about the extraocular muscles. There are 6 extraocular muscles, 4 recti, the superior, inferior, and lateral and medial, and the 2 obliques, the superior oblique and the inferior oblique. But also there is an extra muscle called the orbitalis, and it's well developed in animals. It has a sympathetic supply and it supports the globe, but it's not mentioned here. It's not attached to the eye, it's attached to the orbit, so it supports the eyeball. Anyway, the superior inferior recti move the eye with their names. The superior rectus turns upwards, inferior rectus downwards. The lateral brings the eye lateral, and the medial brings the eye medial. The superior and inferior obliques, however, they exert actions opposite to their names. The superior oblique brings the eye down and lateral, and the inferior oblique brings the eye up and lateral. There is a remark about the course of the superior and inferior recti, because if you've seen a cut section or a transverse or a superior view of the 2 orbits, for example, you will find that the 2 orbits converge to an angle. So muscles arising from the back of the orbit, the superior rectus and the inferior rectus, they arise from a point medial to the longitudinal axis of the eye. That's why they exert their action and pull the eye medially as well. So don't forget the medial pull of the superior and inferior recti on the eyeball. As mentioned before, the superior oblique, this is the superior oblique muscle, you see that? It turns around the trochlea of the eye. That's why the nerve supplies is called the trochlear nerve. Turns the eye laterally, but the superior oblique turns the eye downwards as well. The oculomotor nerves, these are the oculomotor nerves. See, they emerge from between the midbrain and the pons. They supply all the muscles of the orbit except the superior oblique and the lateral rectus. The superior oblique being supplied by the trochlear and the lateral rectus being supplied by the abducens nerve. In addition to the supply of the extraocular muscles, they supply also the levator palpebrae superioris muscle, elevating the upper eyelid. The nucleus of the oculomotor nerve is situated in the midbrain at the level of the superior colliculus, and I showed you that nucleus when studying the sections of the midbrain at the level of the superior colliculus. Now all of you know about the motor unit. The motor unit comprises the neuron and the muscle fibers it supplies. This is called the motor unit. The motor units in the extraocular muscles are very small, means that the each neuron supplies only about 6 muscle fibers, and that why we have that to get a precise movement, very precise control of the eye movements. You can identify the oculomotor nerves emerging between the midbrain and pons, and usually between the posterior cerebral artery and superior cerebellar artery. See, it comes out between these two arteries, and they enter the cavernous sinus on their course to the superior orbital fissure, where it divides the oculomotor nerve into superior and inferior divisions, and to supply the extraocular muscles we mentioned before. The oculomotor nucleus, these are the nuclei of the oculomotor nerve, means the motor nucleus and the Edinger-Westphal nucleus, and this is the oculomotor nerve emerging from the midbrain. The oculomotor nucleus receives inputs from the cerebral cortex for control, of course, of the eye movements. And you can observe that while reading the text in this lecture. For example, you move the eyes from left to right, means that the right eye is moving laterally while the left eye is moving medially, so this needs coordination. This is accomplished by the control of the eye movements. And also, if you're watching a game of tennis, you follow the ball with your head, with your eyes, and with your head, and sometimes with your body as well. This means that there is a coordination between the ocular eye movements and the movements of the neck. Now, the visual inputs via the superior colliculus and pretectal area. The pretectal area is in front of the colliculi. And from the vestibular nuclei, they give information about the movement in the visual fields and the head position, in relation to the object seen or object visualized. Also, do not forget that the oculomotor nerve carries parasympathetic fibers. See that? And you all know that the parasympathetic ganglia are near the organ supply, so the parasympathetic ganglia responsible for supply of the eyeball is the ciliary ganglion. This is the ciliary ganglion. And the fibers originate in the Edinger-Westphal nucleus, and they synapse in the ciliary ganglion, as you can see here. And from the ciliary ganglion, short ciliary nerves supply the eyeball. Now, do not confuse this with the long ciliary nerves. Long ciliary nerves are the ones that carry sympathetic supply to the eyeball, and they come from the plexus around the branches of the internal carotid artery. But the short ciliary nerves are postganglionic from the ciliary ganglion present at the infralateral aspect of the eyeball. Now, the Edinger-Westphal nucleus receives inputs from the pretectal area and superior colliculus, which are the areas in which collateral axons from the optic radiations terminate, and this is essential for completing a reflex arc between the optic nerve and the oculomotor nerves to control the pupillary light reflex and accommodation reflex. The pupillary light reflex involves constriction of the eye pupils by activating the constrictor pupillae muscle, constrictor pupillae present at the margins of the iris. and also involves contraction of the ciliary muscle. This is the ciliary muscle here and here, attached by suspensory ligaments to the capsule of the lens. When they contract, to understand this, this is a cut section of the ciliary muscle. It occupies the circumference around the lens. So if they contract, the space between the ciliary muscle or within the ciliary muscle will decrease, means that the suspensory ligaments will relax and the capsule will be more flexible and the lens will increase its curvature. That's why it increases its power. You understood this? I hope you understood this, because many people think that ciliary muscle contraction results in traction on the suspensory ligaments. No, it relaxes the suspensory ligament because the circumference of the ciliary muscle decreases, so the tension on the suspensory ligaments decreases and the tension on the capsule of the lens decreases and the lens increases in size. Okay. This is a cut section of this is the anterior chamber, and this is the iris here. Constrictor papillae it's at the margin of the iris. This is the ciliary muscle, as you can see here, and these are the suspensory ligaments holding the lens in place. The constrictor papillae constricts when there is bright light to protect the retina from the excess light, and the ciliary muscle is responsible for thickening of the lens for the increase its power for near objects, and this is called the accommodation reflex. So the accommodation reflex involves constriction of the eye pupils, increase the curvature of the lens, and also conversions, means both eyes activating their medial recti muscles together of the right and left to focus on the object. So accommodation reflex involves three categories: reflex constriction of the pupil, reflex contraction of the ciliary muscle, and reflex contraction of both medial recti for conversions of the eyes on the object visualized. Now, the trochlear nerves. These are the trochlear nerves. They are the trochlear nerves supply the superior oblique muscles. This is the trochlear nerve here, supplying this superior oblique muscle. It's the first muscle you see medially when cutting the orbit from or dissecting the orbit from superior aspect. This is the superior oblique muscle. They are very thin nerves. They are difficult to observe in dissection, and they are unique in that they are the only nerve fibers that emerge from the back of the brain stem, and also they cross internally in the midbrain to emerge from the opposite side, as you can see here. So each trochlear nerve supplies the contralateral extraocular muscles. Okay, so it's the only nerve that emerges from this posterior aspect of the brainstem or dorsal surface of the brainstem, and also the nerve that crosses very early, within the midbrain. After emerging from its nucleus, and emerges from below the contralateral inferior colliculus. The superior oblique muscles attached to the common tendinous ring present at the posterior aspect of the orbit and runs forwards, and then the tendon turns around a fibrous pulley called the trochlea, and hence the name of the trochlear nerve, and the tendon goes backwards and laterally to insert itself behind the equator of the eye for the muscle to exert its action on the globe. So the pull on the muscle in this direction exerts action in this direction. Understood this? It's clear. The contracting the muscle in this direction will pull on the tendon that runs this way, so the pull will be in that direction, bringing the eye downwards and lateral. The connections within the CNS are similar to those of the oculomotor nerves for the control of the eye movements. The abducens nerve, each abducens nerve also supplies one muscle, which is the lateral rectus. You can see the abducens nerve here supplying the lateral rectus muscle. The abducens nerve acquired its name because it supplies the lateral rectus, which abducts the eye in its action, so that's why it's called abducens. Each nerve emerges at the junction of the pons and medulla, and long intracranial course on the base of the skull and alongside the sphenoid bone, passing in the area of pituitary gland before entering the orbit through the superior orbital fissure. This is the course of the abducens nerve. The effects of damage and disease on the third and fourth and sixth cranial nerves. Of course, they are the extraocular muscles responsible for the eye movements, so any lesion will results in impaired eye movements. They are traumatized often or frequently in fractures of the middle third of the face that include the orbital walls, and also the surgeons should be aware that in their treatment or handling the midfacial injuries that the extraocular muscles and their innervations may be also compromised by such fractures. Impairment of the eye movement results in lack of coordination of the movement of both eyes. So both eyes will exert different actions or different movement than the other, and this results in double vision or diplopia, as we'll see. For example, if injury to one oculomotor nerve is affected by trauma or disease, all the muscles of the extraocular muscles will be paralyzed except the superior oblique and the lateral rectus, which have their own nerve supply. And because of the lateral rectus and superior oblique exert lateral pull on the globe or on the eyeball, with a paralyzed oculomotor nerve, this results in lack of medial pull, so the eye will be pulled laterally by the unopposed action of these two muscles, the superior oblique and the lateral rectus. This is called lateral strabismus or lateral squint, and it will be fixed laterally and usually downwards because of the pull of the superior oblique. But also do not forget that the oculomotor carries parasympathetic supply to the constrictor pupillae and the ciliary muscles. So these reflexes, the light reflex and the accommodation reflex, will be lost. This results in dilated pupil, dilated fixed pupil, not reacting to light because of the unopposed action of the dilator pupillae muscle, which is supplied by sympathetic supply. Trochlear nerve injuries. The patient may have difficulty negotiating the stairs while climbing up the stairs because they cannot bring the eye downwards and lateral. That's why they have to hold their heads sideways towards the opposite side to the injury to compensate for the absence of pull of the superior oblique. Because the trochlear nerves exit from the posterior aspect of the midbrain or the brainstem, they are liable to whiplash injuries. Whiplash injuries, they commonly occur in car accidents when the body is fixed and the head is freely movable. That's why in front or back impacts in car accidents, there will be sudden violent movement of the head and neck in relation to the body, which is held in place by the seat belt. That's why the modern cars fitted with head restraints and airbags minimize the likelihood of such injuries, whiplash injuries. With abducens nerve damage, the patients will experience diplopia, double vision, especially when trying to move their eye laterally, and may eventually acquire a medial strabismus. Now, there's one trick question about the diplopia in the oculomotor nerve injury. Will there be diplopia in oculomotor nerve injury? The answer is no. Although the eye is moving in different direction, but do not forget that the oculomotor nerve supplies the levator palpebrae superioris. So the eyelid will be dropped. This means that it will obstruct the vision in that eye, so there won't be diplopia. This is a trick clinical question you may encounter in your Viva, for example. But if you elevate the paralyzed eyelid, of course there will be diplopia. Now, back to the abducens nerve injury, we said there will be diplopia and there will be unopposed medial pull of on the globe, means the medial strabismus, because of the unaffected other muscles. As mentioned, this will result in medial strabismus, which is pulling of the eye medially. To test the 3, 4, and 6th cranial nerves, use your finger and ask the patient to follow the tip of a pin or tip of finger while moving it in all directions, superior, inferior, lateral, and medial, to see the extent of the visual field of the patient, and to examine the autonomic component of the oculomotor nerve. Use a flashlight, a pen torch, to observe the pupillary light reflex in one eye and in both eyes, because sometimes it's present in one eye but it's not transmitted to the other eye. This results from a lesion of the MLF, MLF, or the medial longitudinal fasciculus. This is how to test for the functions of the 3rd, 4th, and the 6th cranial nerves. I hope you got the maximum benefit from this lecture, and thank you very much for watching.